Hi, my name's Mel. I'm a respiratory physio. I'm going to be doing a short teaching session today on some basic respiratory assessment and treatment techniques for those of you who are non-on-call or respiratory trained. We'll start off talking about subjective assessment first of all. So as with any patient, you'll want to be beginning with the subjective assessment and checking their medical notes. I would start off with checking with their history of present condition or presenting complaint, see what symptoms they've had when they came in, and then you can compare it to the symptoms that they're presenting with now. You'll definitely want to have a look at their past medical history, checking for any relevant respiratory history or potentially any cardiac history, anything else that you think is going to have an impact on your treatment. Then following through into the clerking, have a look at their diagnosis. What have they actually been diagnosed with? Is it a respiratory condition? Is it something else? Have a little look at their medical management plan as well. Have they had any investigations? What is the onward plan? What are we aiming to do here? And importantly, make sure you're aware of their ceiling of care. This should be clearly documented in the medical clerking when they come in by a senior doctor, and if it isn't, we should all be pushing for these decisions to be made. Have an awareness of their ceiling of care. Are they for full escalation, HDU, ITU, etc.? Are they for a ward-based ceiling? Make sure you just have it clear in your head. Within this section as well, you could find their documented target SATs, so what we should be aiming for with oxygen therapy. And again, if this isn't clear, make sure you're passing that to a doctor and asking them to document that clearly. So next we'll want to take a respiratory history. Ask the patient as you normally would, and if they're unable, make sure you're asking a next of kin, so you're trying to get nice clear information so that if anyone else is reflecting back on your notes, they'll get a really good understanding of what the patient is normally like. So we want to try and establish what their normal symptoms are when they're well at home with respiratory patients. So a number of things. We'll want to know about their shortness of breath. Do they normally experience shortness of breath, or are they not normally breathless? If they do have shortness of breath, is it just on exertion when they're undertaking any activity, or actually are they short of breath at rest? Try and establish their normal exercise tolerance, as this will be important when you're actively treating them on the ward. We don't want to be asking them to do something that's too much that they wouldn't normally be able to do. And with their exercise tolerance, is it actually limited by shortness of breath, or is it limited by another factor such as MSK problems, for example? Do they normally have a cough? Do they normally have a sputum load? And with their cough, are they normally productive, and what's this normally like? Has it changed now? So ask them how often they produce sputum, the colour, consistency, and has it changed now? If they have a long-term condition, do they have a self-management plan? Do they have rescue antibiotics and steroids at home? Are they in touch with any other medical professionals in the community, such as respiratory nurses, COPD nurses, potentially hospice nurses? What do they normally do to clear their chest? Do they have a normal routine? Do they do breathing exercises? Do they have any adjuncts, for example, or not? Those are all really, really important. And lastly, as with any other patient, you'll want to get a social history. How do they manage their ADLs? Won't go into too much more here, but falls history is also really, really important, because again, if patients are coming in with falls or collapses, is it actually related to their shortness of breath? That's important to find out too. So that's pretty much it for subjective assessment. My one bit of advice is to get it right the first time and get as much information as possible, as it will make ongoing treatment much easier and clearer for you. So moving on to objective assessment next, we'll break it up into a look, listen and feel approach, as I often find that this is a nice, easy, systematic way of making sure that you get the information that you need and that you don't miss anything. As with any patient, we'll want to start off with looking, check their NEWS score, so their National Early Warning Score, and remember that an increase in respiratory rate is often an early indication of deterioration, so that's one we want to be mindful of. Escalate the NEWS if they've worsened or if you have any concerns, and it's really, really important to look at trends, so not just looking at one set of obs and looking at, is this normal for the patient, or actually is this new, have they deteriorated? If we start off looking at their respiratory rate, a normal respiratory rate is 12 to 20, so again, look at trends. If someone is normally scoring a 20, has a respiratory rate of 20 for example, but actually on their next score their respiratory rate is only 12, although that's still within normal range, that is quite different. So what has happened? Are they more drowsy? Are they more confused? Have they had any medication which has affected their level of alertness? Yes, they're not going to be scoring for that respiratory rate, but something is different and we should be aware of that. And likewise, if someone has a higher respiratory rate of 21 or 22, you may think, okay, that's not that much higher, but actually if an hour ago it was only 14, what has happened to cause that increase in respiratory rate? That is different and we should be looking into that a little bit more. Moving on to SATs, or oxygen saturations. As I said earlier, it's really important that we know what their target SATs are. So in patients that are at risk of hypercapnic respiratory failure, their target saturations will often be 88 to 92%. Sometimes these can be tailored for individual patients and the doctors should be documenting this. So again, make sure you check. And then for all other patients, normal target SATs are 94 to 98%. So make sure you're checking, and again, important that you have a look at the trends, see what's normal for them. You'll want to review any investigations that they've had in the notes, as I said earlier, but this might be chest x-rays, CT scans, blood gases. Again, it's whatever's within your scope. So if you have been trained to do so, have a look. If you haven't been trained to do so, speak to the doctors and see what they think is going on, or raise it with a trained member of the respiratory team so that they can help guide your treatment. Again, in terms of looking, you want to have a look at the patient, look for any signs of cyanosis, so any problems with oxygenation. An early sign of cyanosis can be your peripheral signs, so you might notice some blue fingertips or toes, and then a late sign is your central cyanosis, so blue or grey lips and tongue. That is a late sign, that is worrying, and that is an emergency, so make sure you're raising that with senior staff. Again, looking at the patient, have a look at their thoracic expansion. Does it look normal? Does it look equal? Or is it unequal? And then have a think about what could be causing that. Look at their work of breathing. So are they using their accessory muscles, or is their breathing relaxed? Does it look normal, or are they working really, really hard? Are they fixing their upper limbs on chairs? Are they leaning forwards? Do they look fatigued? That's another really, really important one. Or actually, conversely, is their breathing quite shallow? Are they not putting much effort into it? And why is that? Is it pain? Is it anxiety? Is it because of secretions? Use it as part of your assessment. The last thing to have a look at is secretions. So if they're already clearing their chest, or if you're doing it as part of your assessment, have a look at the colour, the amount, the consistency. Or is there any hemoptysis, or do they have any blood within their secretions as well? So that's everything you should be having a look at. The next thing we want to do is have a listen. First of all, you can have a listen from the end of the bed. You'll often get a lot of key information just from standing there and observing. Is there anything audible just to your ear? Can you hear the patient? Are they wheezy? Do they sound crackly and chesty? Or are there no kind of added sounds? Or can you hear a stridor? So a stridor is a sign of an upper airway obstruction, and that is a medical emergency which should have immediate attention raised to it. Next, auscultation. So if you're trained to auscultate and you know how to use a stethoscope and what you might be listening for, then do so to add to your assessment. Can you hear anything? Can you hear crackles, crepitations, wheezed, reduced breath sounds, or absent breath sounds? Use it to fit the picture of everything else as part of your assessment. And have a listen to their cough. Is it strong and effective, or is it weak and potentially ineffective? Can you hear any added sounds on their cough? Does it sound like they've got secretions there, or is their cough completely dry? And lastly, you'll want to have a feel. So palpate the chest. Don't be afraid to have a feel if the patient is giving you consent to do so.